So thank you so much for attending for the webinar, Understanding Urinary Diversions, Options, Outcomes, and Living Well. I'm Teresa Blondin, the National Volunteer and Program Manager here at Bladder Cancer Canada, and I'm honored to be facilitating this session tonight. If you're faced with having your bladder removed, there really are a lot of questions and concerns about what life will look like after, and understanding urinary diversions can really help people make informed choices about their unique needs and their lifestyle. Each urinary diversion has pros and cons, and knowing these in advance can truly empower a patient and take away some of the uncertainty. And that's what tonight is all about, providing you with a detailed look at the diversions and hearing a first hand account of what life looks like after bladder removal. And always remember that these webinars are intended for the sole purpose of information sharing and should not be considered medical advice. Always talk to your doctor and or urologist about what is best for you. And if you run into any issues, myself and my colleague Emma Ray are monitoring the chat and happy to help.
And now I'm honored to introduce our first speaker of the evening, Leah Jamnicky, a nurse with over 38 years experience in the Division of Urology and currently the Urology Clinical Coordinator at the University Health Network. Leah has developed countless patient educational materials and programs and is the urological resource for the multidisciplinary staff across all of UHN. One of Leah's greatest attributes is in empowering patients by increasing their knowledge. Leah has co-authored a few books with Dr. Nam at Sunnybrook Hospital. Leah and Dr. Matthew, along with colleagues at UHN, developed the first Canadian prostate cancer rehabilitation clinic. The clinic features a multidisciplinary approach to helping patients survive prostate cancer. This clinic was awarded the second place CCO Quality Care Award. Leah has also been awarded the Queen Elizabeth II Diamond Jubilee Medal in 2013 for excellence in nursing, and she was also awarded the Excellence in Patient Education Award at UHN. She's recognized for her innovative approach to patient care. Leah is also actively involved with many Cancer Care Ontario projects related to urological cancers. Such an impressive career, Leah. Thank you so much for being here. I'll pass it to you.
Thank you so much for having me and inviting me to go over living with urinary diversions and sort of the options and the outcomes and how to move on with our life. So I want to thank you so much for that. So today we're going to look at the different types of options for diversions. We're going to be looking at the Ileal Conduits, the Neobladders, and the Indiana pouches. So when we look at these, here is the picture of the Ileal Conduit, which is an incontinent diversion, so it's brought to the skin. Then we have the continent cutaneous reservoir, which is also known as the Indiana. There's a few other names for that as well. So it is continent, but it is a stoma, and it is brought to the skin. And then we have the orthotopic neobladder, which is a continent diversion where the urethra, the diversion, the piece of bowel is attached to the urethra. So we're going to look at the preoperative counseling of what should be done, some of the health related quality of life with this. So really a lot of consideration needs to be taken when we look at the day-to-day life. Lifestyle considerations when we're looking at things like sleep, sexuality, how do we travel, how do we maintain each of these diversions. There's also financial demands that are very different for each of the diversions. And then is there follow-up clinic availability at the hospital where the surgery was performed, or is there a lot of travel that's involved when it comes to sort of the follow-ups, and that can be an issue as well. So we're going to start off with the Ileal Conduit, probably the easiest of all the surgeries. Probably been around for the longest time since, the 1800s. It's defined as a surgically created artificial opening of an internal organ on the surface of the body or between two body structures. So what it actually means is a mouth or an opening. So there are different types of stomas. There are the permanent. And when we're dealing with bladder removal, the stomas are always permanent and they cannot be reversed. The only time temporary stomas can be created would be more with surgeries that involves the bowels. So say they finished, cancer treatment, or if they've had a fistula, which is, a connection to their bowels where there's fluid that's going into the cavity. So sometimes there's a lot of different reasons for bowels, but these ones can be reversed, but never with the when we remove the bladder. It is a permanent stoma. So how is an ileal conduit made? So what the doctors would do is they would take a piece of ileum. It's located and then closed at the intra-abdominal end, so on the inside. The ureters are then anastomosed, or they're attached to the isolated piece of bowel, and then it's brought to the intra-abdominal end. And then the bladder's removed, and then the other end is isolated and pulled through the abdominal wall. So it's a complicated way of sort of saying that they take a segment, they clip it, they attach the ureters, and then they bring it to the wall of the abdomen. So what are the characteristics of an ileal conduit? So we're limited with the area that we can place that piece of bowel when we bring it to the skin. So usually it's placed in the right lower quadrant of your abdominal area. The end of the stoma and exits through the skin. You will have, or people who do have this surgery will have little stents. And these little stents, you can see them in the picture here. They're tiny little tubes that look like little spaghetti noodles. And those go from the kidney past the area where the ureters attach to the bowel, and then out to the skin to allow everything to heal properly. And those are usually removed a few weeks after surgery. So when you have an ileal conduit, it continuously tends to produce urine. There are some mucus strands that are located in the area, and that is because bowels produce mucus. Initially, a lot of people will find that they have some blood-tinged urine. You can have a little bit of bleeding after the surgery, and that usually does change to clear yellow with no odor after the healing has taken place. So one of the most important things with any of these procedures is really establishing a routine. So it really is trying to keep everything simple. And when you have a routine, it means that you're doing things over and over. So there's a learned response. So it just makes it easier. You limit the number of supplies that you're using and less chances of mistakes. So usually when someone is changing their appliance or their pouch, it's done in the bathroom. It's usually done standing up, and it's usually done in front of a mirror. The pouches are usually changed 1 or 2 times a week, and it really varies on the individual. And sometimes it can be a little bit more often, depending if there's some burning or itching or irritation around the area. But the most important thing is really to sort of limit the type of or the amount of products and accessories that you are using, because less is more. What we mean by that is the less products, the less expensive. So the more product, the more expensive. So less is better. So usually what we would recommend, and this is just a brief overview, and for those of you that may have stomas, it may be a little bit different because we do adjustments and it is individual, but on a average sort of regular standard basis, usually it's important to remove the excess mucus that and the melted barrier with the dry cloth. It's important to cleanse the area with warm tap water. If there's paste or barrier buildup, it's hard to remove. We always say leave it alone, because the worst thing to do is to try to pick it off and pull it, because you are going to irritate the skin, and sometimes you may remove some skin, which will take a while to heal, and then it'll be more irritated. So a lot of times it will slough off with the next change. So then prior to applying the area, you're going to pat everything dry. Most people don't really need to use barriers or skin wipes or anything like that. So those are usually extras and in certain circumstances. So when preparing the flange, it's important to measure and cut the flange opening only like 1/8 of an inch larger than the stoma, so that there's no irritation to the surrounding skin that is exposed. It should actually just be 1/8 of an inch over the size of the stoma. There are times where the pre-cut flanges are available for stomas, but usually these are not encouraged or used until after the swelling has occurred. So usually at around 4 to 6 weeks after surgery is when we would start measuring people for more the permanent appliance. So part of the process is removing the plastic and the paper backing. It's important not to really touch the flange too much, because what happens is you're going to minimize the amount of adhesion. And then some people, just because of the type of stoma, they may need to apply a ring of paste around the opening. It's important not to spread it around the whole flange, but just at the opening. So we usually do recommend a standalone mirror. So some people, the bathrooms, or maybe the way their bathrooms are located, the lights are above the vanity. Sometimes it's kind of difficult to be able to get a good view if you're standing on your tiptoes and trying to see what you're doing. So we usually say a lot of our people that are having the surgery, we have them use we just get them to buy them at the dollar store. They're just the stand-up mirrors that you just put on your counter. So having that on the counter, it's important to try to avoid the skin wrinkles. So if you're standing, everything seems to be smoother. And then it's important to center the stoma in the middle of the opening and then apply it. And we always say it's important to apply gentle pressure to the flange and sort of like a circular motion to promote the adhesion so that you get a good seal. Next. So after attaching the pouch, it's ensuring that you do have a good seal. We need to make sure that the tap or the spigot closure, depending on the appliance, is actually closed. And then once everything is there, holding it over for a few more minutes just to really promote a really good adhesion once the pouch is on. And then you're going to discard all the products. So for sleeping, many people will connect the straight drainage system to allow an uninterrupted night's sleep so that the pouch isn't getting, if you're a heavy sleeper especially, the pouch can burst if it gets too full. So it is better to connect to a nighttime longer tube with a bigger bag for drainage. So when you were looking at appliances and accessories, for the pouches, there's a wide range of costs for what the appliance is. So it depends if it's a 1-piece or a 2-piece. The easier it is, the more expensive it usually is. There are some that are transparent, some that are more opaque, some have a tap, some have a spigot. So there's different types of products. Some of them are cut to fit and they're pre-cut. Some are moldable. Some come with tape where it needs to be taped in order to form a border. Some are convex, some are non-convex. So a lot of that is in working with the NSWAC, the ET nurses that are coming into the home or the clinic to help guide which appliance pouching system is the best for everybody. So there's a lot of different options, and it's sort of working individually with each person to see what works better for them. So there are a lot of different other things that people may see. And again, a lot of it is dependent on the individual. So some people do need liquid barriers. Some people need sealants. Some people need powder for the area. Some people, if they're heavier, depending on the type of work they do or exercise, they will wear the belts to help keep things in place. Some will need deodorant depending on the type of liquids or foods that they're eating. It can alter the smell of the urine, same way as with, if you're eating asparagus, it's that same sort of thing, but it tends to be enhanced when it's outside the body. It's always good to travel with an extra pouching system just in case something happens or one gets disconnected. You're not having to rush home and you do have sort of products available with you. There are some old models that people like, and there are some newer versions. So again, it really does come down to the individual need and the pricing. And again, the different types of adapters depend on the pouching. So sometimes it's easy to get one part of you may be able to get the pouch, but not the drainage adapter. So again, that's where NSWAC or your stoma nurses are a good source of information. So with every procedure that we do, there's a lot of consideration with living with an ostomy. So it's important with everything, looking at sort of dietary considerations, what types of medications you're on. It's important to understand bathing, types of exercise, swimming, return to work, how long do you have to be off work after surgery, social activities, physical activities, intimacy, travel, all these things are very important, and more so than with other types of surgeries where it doesn't really impact the life as life with an ostomy or some of the other treatment options for people that have had their bladders removed. So now we'll go into the Indiana. So as we discussed earlier, it is permanent. So none of these procedures can ever be reversed. It is a continent diversion. So although it is a continent diversion, it still needs to be catheterized. The pouching system is internal, and it needs to be catheterized in order to release the urine. So for this operation, not every patient's a candidate. So you really do have to have good dexterity. There can be no cognitive impairment whatsoever. There needs to be a very strict and really realistic commitment to the catheterization protocols. There can usually be no renal impairment, so the kidneys have to be functioning at a high level in order to have this operation or be considered for it. And then with lifestyle, a lot of people will need to wear a medical alert bracelet as well as to keep the identification in their wallet or in their phone, just to have that alertness there should something occur. So the Indiana pouch, I mean, this is just a simple picture, but it does, and I've taken this off the Bladder Cancer Canada website. So it is a pouch so that you can see that it's built, the ureters are attached from the kidneys to this new pouch. And then there's a segment of the ileum that's brought out to the skin, and that piece of ileum does have a valve that needs to be catheterized. Like I mentioned, again, it's not like the colon, it is the ileum that we use. It's a small portion that it's naturally attached to the colon, and it does have a natural valve. And that natural valve that people catheterize is what prevents the urine from free flowing like the Ileal Conduit. So as the Ileal Conduit is just a straight segment, this one is built and uses a larger segment of the ileum in order to house the urine until it's emptied. So with an Indiana, there are possible side effects. So there can be bowel or urine leaking from where they join the pieces together during the surgery. So it's very intricate, complex surgery. There can be injury to the bowel or some of the major blood vessels and nerves in the area. There at times can be injury requiring a bowel diversion at the same time as doing the diversion, but really that's also a complication that can kind of carry on with any of these diversions that we're talking about today. There can also be a narrowing, or we call that strictures, where the ureter that connects to the intestine, that Indiana pouch, narrows. And as it narrows, it does not let the urine drain into the pouch. One of the other big things is that it can contain too much acid, which can require medication such as sodium bicarb to help decrease the acidity in the bloodstream, because we're housing urine, and the bowels work differently than the bladder from protecting the body, and can also develop stones. So what are the long-term precautions we should take with the Indiana? Like I said, we should put in a card in the wallet. It's explaining the surgery you had and the fact that you have an Indiana. And the reason why we say that it's so important when with the Indiana, with the medical alert and that, is that not everybody, it's not a well-known operation. So people take it for granted should you be in a situation where you would not be able to speak for yourself, and they saw that you had a stoma. What they would then think is that this stoma was not draining. And a lot of times it has happened, not a lot, but it has happened enough times to warrant having to wear the medical alert, so that it would be a trigger for healthcare professionals to say, that is not an ileal conduit. I don't know what an Indiana is, but I'm going to look it up. So they will understand and recognize that this type of diversion actually has to be catheterized, as opposed to some situations where it's been an emergency situation and a person has not been able to speak for themselves, and the healthcare team had taken it for granted that they had an ileal conduit and not an Indiana, and that had to be catheterized, and they were giving them lots of fluid because there was no output, and in reality it could burst the pouch. So it's always important, it's a trigger, and that is why as healthcare professionals we do look to see if there's some sort of, at times, medical alerts or any information, so it helps us to manage the individual better. So this is important to let healthcare professionals know, and even if they don't know what an Indiana is, it would then lead them to look it up and how to manage it. So prior to going home, it's always important to, when you're in a hospital setting and you're being taught how to look after each and every one of the diversions that we're talking about today, it's really important to sort of practice that process of how it's going to be at home, because it's a lot easier when you're in the hospital and you have, a nurse or a healthcare professional, the NSWAC nurse, who's handing you supplies and saying, open this, do that. So a lot of times being in the hospital gown. So a lot of times being able, we call it pretend you're at home day. And it's usually the day before, 2 days before someone goes home. So what we do is we practice, how is it at home? So the individuals, we have them dressed in their clothes as to what they would be dressed in at home. And then they practice with, getting dressed and undressed, changing the pouching from start to finish, independently irrigating the 2 tubes that they're going to be going home with. So, and setting everything up. So being able to go through all those processes really helps to decrease the anxiety, because it's different when people go home and then all of a sudden it's like you're now setting things up, and you've been used to having everybody else do it for you. So it's not just a technique, but it's a process of organizing everything to make it simple. So with these surgeries, there's a few appointments involved. There are a few tubes, and not every surgeon uses 2 tubes when they're doing the surgery. The majority do, but not everyone does. So the process for appointments is usually people will come back to have what we call a pouchogram. And what that is the doctor will put some dye into the new pouch, and they want to look at, is the pouch a watertight seal? Because we are using a larger segment and we're doing a lot of sewing to create a pouch, we want to make sure that everything is watertight. So prior to taking out what we call the malacot or suprapubic, we would have that. The two of them are clamped, and then what the person would do is we would remove the catheter that's in the stoma, so in the Indiana pouch. The Malacot, we call that sort of, instead of always trying to get a name to it, I always call it a safety tube. So that one is clamped. So that's always, if anything can go wrong or something's going to go wrong or you can't catheterize, it's easy access to be able to uncap it and release the urine from this new pouch. So this is where the nurses in the department, usually it's done like in a cystoscopy department or a clinic that has the supplies. So after they do the pouchogram, the Malacot is clamped, and then people are taught how to catheterize this Indiana pouch. This is just sort of an idea of where the stoma, it's usually located. I think I forgot to mention that before. It is located like near the belly button or in the belly button area. The one catheter is clamped, and then the nurses review the, like I said, the catheterization and irrigation schedule. So usually the catheterizing schedule is every 2 hours, and at nighttime every 3 hours. And that's usually for the first month. Sometimes it's a little bit longer. It does increase over time, and there's no time frames that are absolutely 100 correct. These are guidelines. And the reason being, a lot of the catheterizing sort of schedule, when people are catheterizing their stomas, their Indianas, is that there's a lot of factors that are involved when it comes into mucus production and the amount of urine and how much they're drinking. So this is where having a lot of cognitive ability to be able to find the rationale behind I'm okay to do it now, or I should wait, or I need to do it more frequently. So these are just sort of guidelines, but they're not exact time frames. It's important, like I mentioned before, that when we're managing with the Indiana, it's very important to keep the catheter schedule so as to ensure the Indiana pouch does not overfill. So we did mention that if you can't speak for yourself, it is important though, even on a day-to-day, to really not go longer. And this is where we stress to people, one of the biggest issues with the Indiana is because it's an internal valve. The more urine that's in the pouch, what happens is all this urine in the pouch is putting pressure on the valve. So what it's doing is it's tightening the valve. So when someone goes to finally catheterize, they can't pass the area because of the back pressure. And sometimes what happens is people do have to go into the emergency department if they don't catheterize in a timely manner because of the pressure of the valve. They usually will have to go into emerge, and then the urology would be called, and they would have to put a guide wire in through past the valve and then run the catheter through it to relieve the back pressure in order to drain the urine. So when we're doing teaching, when we're explaining the process, when a decision is made to have this, it's very important to understand that there's stringent criteria that needs to be followed in order to manage it in an appropriate manner. So it's also important, and we do know this, and a lot of people, when we're doing the education for the surgery, they'll say, you know what, I'm not going to get enough sleep. If I have to get up every 3 hours to do the catheterizations, what kind of life is that? And even though maybe it's every 6 hours, once all the healing and everything is completed down the road, but even still, that's not enough. So initially, we do know that this can be an issue. So we will say to people, especially in the fresh sort of post-operative healing process, while they still have the Malacot or that safety tube in place, is we do tell them just to connect to the night drainage bag overnight. So then that way, if they so they can get up, not have to get up at night. They can just get up to the night drainage bag. But that's again for a short period, because that's really only for the first month until that safety tube or Malacot is removed. And then it's sort of going back to that strict criteria. So one of the issues with the Indiana is that we talked about the valve and how that valve has to be passed in order to empty the Indiana. That valve usually will not allow a straight catheter to pass that area. So with this type of surgery, with the Indiana, people usually have to get what we call the Coude or curve-tipped or Tiemann catheter. These catheters automatically, because they're special, they're not a straight catheter, automatically go up in price. So these Coude catheters, depending on how often you have to catheterize, flush, how many times you can use them, and it's not the same for everybody. Some people develop allergies. They can only use the catheter once and then they have to throw it out. It can't be cleaned and reused, so some people can reuse them over and over and over for a week or so. So there's a lot of different sort of variables that come into play when you're dealing with this type of lifestyle with the Indiana. We don't know. And that's why a lot of times when we are speaking to people, they need to understand that the catheters on average on the low end are about $5,000 a year for the catheterizations. And it can go up to $35,000. So we have had people that they cannot clean the catheters. They're very prone to infections, and cleaning the catheter introduces bacteria no matter how they try to clean it. So they have to dispose of it every single time. So they're going through about 4 to 6 of these a day. And that's where you're getting into the $35,000 mark. And that's where, again, with these catheters or any sort of supplies when it comes to bladder cancer surgeries, where we're removing the bladder, is there's a set limit when it comes to assistive devices program and what they will cover. And again, catheters are not covered by insurance. So it's usually the cost is to the individual. So I know June Hill spoke back in June at one of the bladder cancer webinar, and she really had some useful information. And I do urge you, if you're looking at any of these options, is to go back to that webinar that June did. And I've actually been having my patients look at the webinar, because she really had some useful information in regards to federal resources, disability tax credit resources. If eligible, sometimes it can be put on the income tax to decrease the income tax. And then we do have the Provincial ADP Assistive Devices Program, covers around just over $900 yearly for the cost of some of these supplies. And again, this this goes to all the different sort of procedures. I will say she did mention that there were things when it was taking time, so that something that was time consuming was a factor that helped to get that tax credit, disability tax credit, because of the number of hours that were spent. And this is where, especially with the complex Indiana and Neos, that would fit that criteria. So again, life within Indiana, very similar to, again, with the Ileal Conduit, where we're looking at dietary considerations, medications, bathing, exercise, swimming, return to work, school, the different physical activities, social activities, again, intimacy and travel. And we're going to go into a little bit of more of those all together. So now we go into the Neobladder. So the Neobladder is, as well as any type of removal of the bladder, is permanent. It is a continent diversion, but this operation, a Neobladder, most resembles the natural bladder. So when we're looking at patient selection, again, this is very similar to the Indiana. So not everyone is a candidate for this type of surgery. Again, there is a requirement for good dexterity. there could be no cognitive impairment. So you really have to be able to problem solve. There has to be a commitment again to possible catheterization, especially with irrigation protocols and catheterization in the initial postoperative period. There cannot be renal impairment because the kidneys do have to work harder with having to recycle the waste products a second time. So they do have to work harder. And then again, lifestyle considerations with, needing to wear a medical alert bracelet and having people aware of the type of diversion that you have. So a neobladder, very similar sort of mechanism, but again, we're taking a larger segment of bowel and we're sewing it. We're creating a pouch, so it's not a nice sphere. It's got a lot of nooks and crannies when they are doing the sewing. So there's a lot of areas where mucus can be like stuck in those areas, and that's why things like irrigating is so important, which I'll go into. And then that neobladder is then attached to the urethra. A surgeon, when they're doing a neobladder, will take a segment of the intestine, and when he's forming the pouch, like I said, it's attached to the ureters and the urethra. So usually what happens is, because urine passes very similar to like a normal bladder, but the difference is it's not a muscle, it's a bowel. So people have to use abdominal muscles and certain techniques in order to empty the urine, because we no longer have the sphincters and we no longer have the muscle that the bladder has. So usually with this surgery as well, it's mostly performed on men. It's not that it's not performed on women. Sometimes it's technically more difficult. Men have a longer urethra. So for women, sometimes technically being able to construct the neobladder to a shorter urethra can be difficult, and it can pose a problem. And again, an intestine is not a bladder. There's differences, and I'll explain a little bit more as to why as we go along. So this is just sort of a picture of how people are going to be going home, very similar to the Indiana, where somebody's going to have the Foley catheter. So in the Indiana, it was in the stoma that went into the Indiana. And this one is the catheter will go in through the urethra. And then you also have the same sort of safety tube. Some people call it a suprapubic, some people call it a Malicot. I call it a safety tube. So it's just going into the neobladder in a different direction. And it's there should anything happen to the Foley catheter, you have another access point for urine to drain. So, and this is especially very critical in that initial first 2 to 3 weeks after surgery, when a lot of the healing is taking place. So the goal of the irrigating schedule is to prevent infection and blockage. So usually what we would do is we would irrigate the 2 tubes with saline. So usually what we would do is insert about 100 mils with a syringe, looks like a turkey baster. It's got a special end on it that looks very similar to like the catheter that it attaches to, and people will draw back and insert 100 mils and then draw back. And what we're doing is we're irrigating or flushing. So we're getting rid of the mucus that is collected in that area. And after a few times of irrigating, if there's no more mucus, then we say it's okay to hook everything back up to the drainage bag. So we always want to make sure that we're keeping the neobladder, same as when we do the Indianas, free of mucus. So same as the other surgeries, we like to do the going home and pretend you're at home day, because really I can't stress this enough. A lot of times just that ability to be able to kind of get into the mindset of setting everything up and having your own clothes and being able to do, you know, the flushing and the irrigating and the changing of the tubes is really important. So similar to the Indiana, people will have a cystogram, which again is inserting some dye into the neobladder. So you can see it sort of within the area. That white area is where they've put the dye in. So what they're looking for is they want to have like they want to see a sphere. They don't want to see any clouding. If there's clouding of that dye, that's sort of like fuzzy around the neobladder, what that means is there's some of the dye that's escaping and things are not watertight. So if things look watertight, what they're going to do then is they're going to remove the catheter and then they're going to clamp the suprapubic malachite or safety tube, whichever way you want to call it. And then the person is going to be taught the Valsalva and Crede Maneuver to empty the bladder. So usually the voiding schedule, again, very similar to the Indiana. These are very similar when it comes to protocols and process and healing and management. So very similar, same sort of thing, having to set the time. The reason you have to set the time to empty your bladder is you no longer have the mechanism to say, my bladder's full. Because when you have a bladder, there's a signal that triggers your bladder's full, goes to your brain and back down. You go to the bathroom, you release the urine, and then you tighten the sphincter and you walk away, right? So these are all sort of automatic and there's triggers. Those triggers are gone when you have the neobladder. So I did mention the Valsalva. So the Valsalva maneuver is an exercise to relax the pelvic floor muscles. So what happens is what we want people to do is to contract the muscles of the abdomen and then push down the lower abdomen with their hands. So it's being able to sort of push on their abdomen like you're kneading dough. And that pressure along with the Crede is what helps to push the urine out of the neobladder. So like I mentioned, the Crede is the one where you're applying the manual pressure. So with the Valsalva, it's relaxing. And then you're using the manual pressure on the bladder to excrete. So it's usually the combination to be able to release the urine and allow for a smooth flow of urine. So a lot of times for men who are having the neobladder, they have to sit. They can no longer stand to empty their bladders, but they do have to sit and do Valsalva Crede. So with the neobladder, once all the tubes are out, we do tell people that they should have like their fluids mostly during the day, as opposed to, closer to bed. So we do say that, they should set an alarm to empty their bladder. They should catheterize before they go to the bladder or empty, depending on what stage they're at. But initially, we do say catheterizing, especially to get out the mucus. Because you no longer have the sphincter that controls the urine, that's that trigger that you have, that release of that sensation that your bladder's full, that sends a signal to the brain and then back down to tighten. That's removed. So a lot of people will be incontinent at night and they will have to wear a diaper at night as they don't have that sensation. So similar to the Indiana, with the second appointment then, a lot of it is assessing like where people are at with the voiding. The malachite is removed. So for those people that were unclamping the malachite or the suprapubic or the safety to sleep during the night, that is no longer going to be an option for them. So what they need to do now, and they were also continuing to flush the malachite during this time period. So now the individuals have to be taught how to do clean intermittent catheterizations of the neobladder and flushing the mucus out. So it's usually done at the appointment when we're removing the Malacot. So one of the downsides is that some people experience leakage or incontinence with this type of surgery. It takes time to train the new muscles in the neobladder. And even with the training, the person may not be completely continent. So you may have sort of like a stress incontinence, but it's more just sort of overflow incontinence. You do need to use the Valsalva and Crede in order to empty the bladder. It's not too many people that can actually have strong enough muscle tone to be able to just use their muscle tone to completely empty the neobladder. One of the two sort of complications, or not complications, but well, it could be side effects. So not everybody is, it's a very precise, pristine, surgeons really have to have a lot of experience with doing this surgery because the majority are down that stream where you do have the ability to have those time voids. For some people, they're fully incontinent and they have no control and they always have to wear a diaper. The other extreme is the individuals who everything is too tight and they have to catheterize in order to empty the urine from their neobladder. So what long-term precautions should people take with their neobladder? Again, it's sort of putting the, the card in the wallet and having the medical alert bracelet so people do understand, especially if someone is having to catheterize the neobladder because they're unable to avoid. That's especially important in that aspect. But it is important to carry that identification that you have had that type of surgery. Again, same sort of life with a neo or similar to the other ones. So choosing the right surgery. So there's a lot of information, obviously, between, and that's only really like the tip of the iceberg, a general overview for the three operations that we've gone through. But it's really determining the right mode of which way we're going to go. And it really is a challenge for the surgeons. There's a lot of factors that are involved and it's not just I want it. So literally we really need to look at the disease stage and the grade. That's probably one of the most important factors starting off from the very beginning. It needs to be a lot of consultation, and that is with the whole team. So that's usually the surgeon, the NSWAC, sometimes there's a clinical nurse specialist, sometimes there's a coordinator, somebody who has experience in this area, because there is a lot of decisions to be made, because once a decision is made, there's no going back. This is your choice and you're going to have to live with it. So we need to make sure that you're making the right decision with the right information and ensuring that you have the best pathway going forward. Next. So the restrictions, and I will say for people that are with the Neo or the Indianas, again, like when we said about when we're looking at patient selection, there are things that, again, can be limiting factors that maybe you're a great candidate, but do you have enough bowel segment available? So say someone who has had, Crohn's disease or different inflammatory like bowels, different issues like Crohn's across their lifespan, they may have too much damage to their bowels to be able to remove a larger segment to go ahead and move ahead with this type of operation. So they would be more, the surgeon would be more inclined to go with the Ileal Conduit as opposed to one of the other diversions. Again, manual dexterity is really important with the operations. You cannot have psychiatric impairments, neurological disease. People have to be able to problem solve with the Neo and the Indiana, because there's a lot of things that can come into play where they can actually do a lot of bodily harm if they do not follow the process. Age is also a factor because the healing process, the whole from start to finish, a lot of people say it's 9 months to a year before they really feel that they've got their life into a routine enough that they can really say, I don't really feel that this is impacting my life, as opposed to an ileal conduit, which is usually maybe 3 months. So there is a big difference when it comes to adjusting to the new diversion. There's also an issue with supplies or the cost of supplies. So can you afford it? There's no way of knowing. Are you a person who's going to be the $5,000 a year? So can you afford $4,000? Or if it does cost $35,000, how are you going to be able to manage that? So that's where with the catheter. So that's where there needs to be a lot of thought and consideration because it's not always that perfect pathway. So if there's going to be tumor reoccurrence, that's also an issue because when there is tumor reoccurrence, a lot of times that's further treatment, and that further treatment would be some sort of chemo. And because it is chemo, the kidneys are working harder with those two surgeries. So a lot of times that chemo can really injure the kidneys because a lot of chemos are then filtered through the kidneys as well. So it's a lot of, insult to the kidneys. Somebody who has the neobladder can never undergo radiation because radiation to the bladder, to the prostate, different areas of your body are fine. Bowels cannot be irradiated, so you burn them. So it would more or less be a decision of you're burning the neobladder. So a lot of times you can't do the radiation to that area for fear of damage to the neobladder. Sometimes we have to put nephrostomy tubes and just say we just have to go ahead with the radiation and just burn the neo. So again, that's not till like more advanced, but it can be an issue, and that's where there's a lot of discussion again. And again, the renal function is one of the key components. So you're probably thinking, so why does she keep going on about, the how the bladder functions or how the bowel functions? So going to go through that now because this is where it's important. So when you look at your bladder, it is such a distinctive organ and it's characterized by a protective lining. And that lining safeguards our body from the waste products that are filtered from the kidneys until we pee them out. So it also has a muscle. So that muscle, when the bladder's full, will send a signal to the brain to say, hey, I'm full. Send a signal down. It'll squeeze down on the urine to expel the urine. And then it's protected all that while with a special lining. So all those waste products are not being reabsorbed back into the body. So this is where the bladder is very, very unique, and there is nothing else like it in the body to substitute it with. So we're going to look at intestines, and this is where I say to people, okay, so why are you using intestines? So intestines can be molded. It can be made into a pouch. It's your own body. So it's no sort of like reaction or artificial things, but this is where it limits what can actually who can have the surgery, for what reasons, and some of the things that can happen by using a segment of the bowel. So what happens is, look at the function. The function of the intestines is, the primary function is to absorb nutrients. So when we're eating foods, your bowels are taking those nutrients and it's using it to help make us healthy. So when you use it as a reservoir, those bowels do not wake up and say, hey, I'm a bladder. No, it's never a bladder. It's always a segment of bowel. So it always continues to function as a segment of bowel, but with a new job. So in saying that, the bowels also produce mucus, and that mucus is not harmful. It's important in order to allow for that food, for the nutrients that we're taking in to pass along our GI system. So what happens is it's helping to make that journey of those nutrients until we expel it out. So it's taking everything out. And in a movement, like in a peristaltic sort of movement, it's not an issue. So when it's in a stagnant position, so when that mucus is stagnant, it's not moving along, it can block ureters. Why? Because it can get hard and it can get crusty. So what can happen is it can get stuck into all those nooks and crannies of when somebody has had an Indiana or a neobladder. And that's why we have to irrigate it. We have to flush that mucus out of those pouches, the neobladder, in order to not allow it to become crusted over. If it blocks the ureters, urine is not able to flow from the kidneys, people can get hydronephrosis. And what that is in simple terms is the kidneys swell, and then you can get infections. So the body, we have to eliminate that mucus, and that is done by the irrigation. Now, that can be cumbersome, and it can be time consuming, and it can be expensive. So there is a medication, and it's called acetylcysteine. So this medication, so acetylcysteine, which is also known as Mucomyst, it's very expensive. So now we found a way of how we're going to decrease mucus in individuals. And then we find out that it's going to be over $1,800. It's one of those medications that it's not covered by OHIP. It doesn't covered by us filling out Section 8, or many insurance plans will not cover this medication. So again, there's another added cost in order to be able to bring down the cost of using something that you may need to help simplify your life by not having to flush as much. So we were able to find a supplement that's produced by BioAdvantex Pharma. It offers the same benefits as the pharmacological version, but at a much lower price. So it's $1,800 for the Mucomyst, whereas the BioAdvantex Pharmanac is actually about $40 a month. So it really does help to decrease the mucus production, which really does help. So this is the supplement. I'm giving you a picture because what happens is Pharmanac is, I always say buyer beware. And the reason being is when you're a supplement, any supplement company is not, they're not governed by the Food and Drug Administration in the US or Canada. There aren't the restrictions to actually say what you are, how it works. And some medications actually have, or even supplements, if they're exposed to different conditions, they degrade, so they're not effective. So in saying that, acetylcysteine, this type of medication, like I said, Mucomyst, so that's the pharmacological grade, is very sensitive to light and air. So when we're giving it in the hospital, what happens is it comes in a dark vial. Sometimes it'll go through the intravenous, in which we put like a dark bag over it in order to protect it from the light and air. Or if the people are given it to drink, it's poured into the juice or whatnot, and they drink it quickly, and it doesn't sit, because the longer it sits and is exposed, the more it degrades. So this company is the only one that actually makes the medication where each tablet is individually packaged in a foil. So once you open it, it's effervescent, you put it in a glass of water, and then as soon as it dissolves, you drink it. you've got maximum potency, as opposed to brands that it's in a bottle, but as soon as you open it, you're introducing air, and then once it hits the light, then it starts to degrade as well. So they're probably not getting the full benefit of the acetylcysteine of going with other types of supplements. So when we're talking about the continent diversions, metabolic issues may arise with the continent diversions, again, because like we mentioned, there's larger segments of the intestines that are used. When we look at the waste products that are being reabsorbed, so the bowels absorb nutrients. So in the position now of the bladder, they don't, again, like I said, they don't wake up and say, hey, I'm a bladder. They continue to function the way they did. And that's where people can develop metabolic issues. So that's where, what we mean by that is those waste products are being reabsorbed back into your bloodstream. And what that means is the kidneys have to work harder, because not only did it filter those waste products already, now it's being stored in a reservoir that's now continuing to absorb those waste products again. So one of the ways of decreasing that reabsorption of those waste products is by diluting it. And the only way to dilute it is by drinking 3 liters of water a day. So that doesn't include everything else you're drinking. It's 3 liters of water a day to really keep that urine diluted. So what's being reabsorbed is not causing these issues systemically within your bloodstream, where it can lead to the kidneys having to work too hard. So when it does that, it can also lead the kidneys to, if they're working too hard, to decrease the kidney function. So that's why we know these 2 surgeries can impact renal function. That is why we say you have to have good renal function, because if you have poor function going in, it's going to decrease. So that's where we don't want people to have to go on dialysis if they have poor function and then we're doing the surgery. So that's why all these factors intertwined together are important in the decisions. So complications. So with the ileal, a lot of them are similar. A lot of them can have, any type of like stenosis. And so what we mean is anywhere we've attached things, like the ureters to that segment of bowel, or to the skin, or to the urethra, those can be areas where people can get strictures, and it can be hard to catheterize or have the urine flow out, like from the ileal conduit, or causing hydronephrosis to the kidneys, which can cause pyelonephritis, which is kidney infections. So with the ileal, people can get skin irritations if the flanges are cut too large, and then the urine is sitting on the skin over time. That can cause a skin irritation. Hernia is possible, or prolapse of the stoma is also possible. With the India and the Neo, they're similar, but they also can get stones, because again, we're altering that metabolic sort of ability of what the bowels are doing. So we're changing the structure of what's being stored. So some people can, plus you've got the mucus that can harden and cause like stones as well, right? So these, they're very similar, and each one is a little bit different in that the ileal can have the skin irritation, and then the Indian and the Neo can also have the stones. So one of the other things, and it's more with the Neo or the Indiana, is that this is one of the big issues, is that E. coli is always present in everybody. It's in our bowels, and it causes no problems whatsoever. In the continent diversions, E. coli, if it enters the kidney, it can cause pyelonephritis, which can lead to sepsis. So that is where you have a very severe infection requiring antibiotics and hospitalization. So one of the things that we tell people, again, this is why it's important to drink lots of liquids, but it's also important because a lot of physicians, if a person comes into emerge and they would look at somebody who's had the surgery, and they would do a urine sample and they say, oh, you've got E. coli, we're going to put you on antibiotics. What happens is you're always going to have E. coli present. So it's one of those where it's being aware enough to discuss with your family doctor, or again, if you're going into emerge or having the family member relay this, is that they should not be treating the E. coli unless you have symptoms like fever, chills, temperature. It should not be based on just that it's positive for E. coli, because it'll always be positive for E. coli. So getting back to life, so in the immediate sort of post-operative period, we usually do say that for any of the surgeries, it's important not to do any heavy lifting. We don't want you to get any hernias where we did the surgery. So usually we will say the best thing, like nothing core. For that 6 to 8 weeks. So we usually say walking increases circulation, helps with the healing process, gets the oxygen to the tissues, increases energy, increases cardiac output. So walking is about one of the most important things. And it also helps to decrease the chances of developing blood clots in the legs. So this is another one. Sounds easy, reduce stress. Sure, can't do it. But it's important to really always try to encourage, and it's important for you as someone who is having surgery or getting a diagnosis to really make sure that you verbalize your fears and anxieties. As a healthcare professional, I always try to bring that out, because I find that we can help you, and there are services available. Not everybody has somebody who knows somebody who's had this operation. There's usually a lot of support groups that we can hook you up with. There's usually healthcare professionals that are here to help. So being able to find ways to reduce stress, better night's sleep is better, because then the less sleep, the more anxiety, it increases the fears. It's like a vicious cycle. So it really is important to either speak to family members or to your healthcare professionals, and they can help set up some resources for you. So with the diversions, so sexuality is huge. And each and every one of the operations for both male or female will have some sort of ramifications. And one thing I always say to the new nurses who are coming onto the nursing unit or into the clinic areas, I always say this is very important that we bring up these conversations with people, because a lot of times that's not in the forefront, and a lot of times people are afraid to ask. But I always say to them, it's the World Health Organization that states that it is a human right to have access to information in regards to how a treatment will affect their sexual function, and how it integrates with the somatic, intellectual, emotional, and social aspects. And yet, we fail in this area. It is recognized. It is something that is a right of every person. And yet, as healthcare professionals, sometimes we fall in this area. So after surgery, some men may struggle with erections because the nerves that are needed for the erections can be affected, in that what happens is we have to move the nerves out of the way. And any bruising and trauma of moving the nerves that deal with erections will not allow the electricity to reach its destination. So in saying that, a lot of men will develop erectile dysfunction, and that's something that we kind of look at options ahead of time, but usually most centers will have programs to be able to help recover in that process. So in saying that, though, one of the important things that we really explain to people, that experiencing erectile dysfunction doesn't, decrease their masculinity. And many men without bladder cancer also face sexual challenges. So there's a lot of things that we can do to help with the process, but having bladder cancer does not make you less masculine. Same for with women. So after the procedure, they may experience some discomfort or challenges during their sexual intercourse due to potential narrowing or shortening of the vagina, especially if they haven't reached menopause yet. This would trigger it if the ovaries and the uterus are removed at the same time, which they often are with this type of operation. A smaller vagina doesn't mean that you can't experience orgasms. Many women who have undergone cystectomy with some vaginal removal still have orgasms, but some do find that they may find it more difficult. And nerve damage could also affect the ability to orgasm, the same as with men who are having this operation. The important thing that I always review with people is bladder cancer does not diminish your worth as an individual. Sexuality is personal, and many individuals refrain from inquiring about it. That's why I always bring it to the forefront when communicating with people. Some people do say there's a feeling of self-perceived unattractiveness, and they feel that their partner is not going to be in love with them anymore. And one of the things that I do is I say, if the roles were reversed, if it was your partner in this situation and not you, would the surgery define them? And they always say, absolutely not. That's a stupid question. Why would you even ask it? And I said, but you just answered your own question, right? So a lot of times it's a self-perceived, but you project it that other people are going to visualize you as that individual, when in reality it's yourself, and it's not perceived by others. There are many resources that are available. I know Bladder Cancer Canada has excellent support groups. So there's a lot of areas, and there's a lot of informative webinars where people discuss this. So I do encourage people to watch those. So quality of life for all diversions, and this is where it's interesting, because at a year, all diversions, the quality of life is high. So on average, like I mentioned, ileal conduits do have a shorter recovery period, just because it's not as intensive a surgery, not as hard to manage. Those with stomas, though, often fear more the body image changes and how they will be viewed, by their spouses and family and friends and that sort of thing. So, but literally at a year, with all those types of surgeries, they all sort of come together. There's differences within the year of all of them. It gets complicated not going through it, but at a year, everybody comes to, they're happy with the decision they've made, with the treatment option that they've chosen. So, I mean, if we look at embracing the future, I've been doing this for 38 years. When I look at different treatment options, we can only see, like, in the future where we're doing better and better. I think one of the biggest things is really, as well as not treatment options, yes, it's increased awareness. And what I have really found over the years is by increasing awareness, you're decreasing the stigma. And if you can decrease the stigma, it really does help with one's ability to cope with the diagnosis and their ability to see how society may view them. So this is where, I mean, living your full life. So there are so many people, and this is one of the things that I really kind of love about social media. A lot of things I don't like, but one of the things I love is years ago, we didn't have this, right? So having people of all ages, all, whether male, female, he, she, they, them, whatever, they're on media, social media, and they're saying, this is me. This does not define me. And I think this is one of the greatest things that really social media has come through. So I think this is amazing that people are not being, they're not taking this as, this is who I am. I am an individual. I am not defined by my stoma or my bladder cancer. And this is just, again, it's no longer taboo, and that I find really fulfilling as a nurse, to be able to see that it really is no longer something that really people are saying that determines or undermines their identity. Thank you. So I hope you found this information helpful. I think I went over time a little bit, and I apologize for that. It's just sometimes I get wrapped up in my stories.
No, that's great. That was such a comprehensive review, so I really appreciate that. So I'm honored to introduce two of our peer support volunteers who are with us tonight, Gloria and Dave. These incredible volunteers speak one-to-one on the phone with newly diagnosed people facing bladder cancer, and it really helps alleviate their concerns, provide guidance, and explain quality of life after surgery. Oh, and I see Clarence is here. Awesome, Clarence. I'm going to move you to panelist. Great. So we have Clarence here as well. So Gloria will speak about neobladders, Clarence will speak about the Ileal Conduit, and then Dave will speak to the Indiana pouch. So I'm going to start with Gloria. So I will pass it over to you. Thank you so much for being here.
Well, thank you for having me. Okay, I'm going to start by saying someone who prides themselves on living a healthy, active lifestyle, seeing blood in my urine was a concern. So I called my doctor and went in to see him, and he sent me for an ultrasound. The next morning, I received a call from the doctor's office, which is never a good thing, telling me he wanted me to come in. So I went in to see him. He walked into the room and said, "You have a tumor in your bladder and it's malignant." I said, "Are you saying I have cancer?" He says, "That's exactly what I'm saying, and you are in for the fight of your life." Wow, that started the whole uh, ball rolling. After my doctor's visit in early December 2016, I was referred to the urology clinic for a cystoscopy. Then a turbot was scheduled on December 19th, where cells from my bladder were removed and sent to pathology. In early January 2017, I went back to the urology clinic to get my results. The doctor walked into the room and said, "You have a high grade, very nasty muscle invasive cancer, and your bladder needs to come out." I was then sent across the hall to another urosurgeon who told me he would do the surgery, and because of my age and fitness, I would be a candidate for a neobladder. I had never even heard of a neobladder. So after having discussions with him about my options, I decided, because of my age and my active lifestyle, the neobladder was a diversion option for me. So in February, I started chemotherapy. I did 4 rounds. Then on June 13th, 2017, I had my surgery where my bladder was removed, as well as a complete hysterectomy. I spent 13 days in the hospital, walking as much as I could each day and learning to flush the catheter that was in my neobladder. I was sent home with the catheter, still in my neobladder, for an additional 3 weeks. At home, I flushed my catheter every 4 hours and worked to regain my strength for the job that lay ahead, which was training my new bladder. After my catheter and JP drain were removed, the nurse showed me how to self-cath, which was suggested to do first thing in the morning and before I went to bed as part of the training regimen. She also told me to try and pee every 2 hours and to ensure that I was drinking 8 glasses of water every day to keep the mucus flowing in my new neobladder. I was totally incontinent, having to wear Depends underwear and the biggest incontinence pads around the clock. This was a very challenging time for me. Suddenly, I had to adjust to my new reality of living with a neobladder and training myself to void my urine with the goal of being continent at some point. I decided to reach out to Bladder Cancer Canada, and I spoke to a support volunteer who had a neobladder and was told to be kind to myself and to be very patient. It's like training for a marathon, is what she said. She sent me a daily log that she used to measure the amount of urine voided and catheter amount voided. I used a hat which fits under the toilet seat to measure the amount of urine I was voiding every 2 hours. I kept a log for about 14 months so that I could see the progress that I was making over time. One tip that I learned is to stop drinking water 2 hours before bedtime. Otherwise, you're going to be up more often than you like. The support volunteer also suggested I find a physiotherapist specializing in pelvic floor health. I called Kira Physiotherapy, and they were very interested in me because they had never heard of someone who had their bladder removed and had it replaced with a new bladder made of small intestine. I had numerous visits to the physiotherapist over the next year, learning to do pelvic floor muscle training. It took me about 14 months to where my neobladder stretched and was able to hold more urine, and I was able to pee using the Crede Maneuver. Training and exercising these muscles helped me to eliminate and reduce urine leakage. I focused on getting continent during the day before I tackled the night. At night, I was setting my alarm every 2 to 3 hours to void. My neobladder grew stronger and more efficient in year 2 and 3, and I was able to go longer during the day and at night. Things were going well with my neobladder. Then in April 2019, my bowel twisted in 2 places, and I had to have emergency surgery. This was a setback for me because I was not able to void because of the abdominal surgery, so I started to self-cath for about 4 months. I was never able to totally empty my bladder after that, so I just threw in the towel and decided to self-cath full-time. I now self-cath about every 3 to 4 hours during the day and once during the night. It's fast, efficient, and I haven't had any UTIs or any other concerns. There are costs associated with my neobladder. I use a new catheter each day, washing it well with soap and water after each use. The cost is about $99 for 100 catheters, and these last me about 3 months. I also buy disposable if I'm out and about or traveling. The cost is about $90 for 30. I purchase the catheters from a medical supply store, and 80% is covered by my health plan. I also use incontinence pads at night at various costs depending on the size and the amount, but about $10 a month. I applied for the disability tax credit and claim this each year on my tax return. It's a beneficial credit, and I'm so glad we have it. My everyday life has changed with the neobladder, but I enjoy doing everything I did before my surgery and more. Choosing the neobladder was the right choice for me. It was a lot of work, but you get out what you put in, and I'm very happy with the outcome. I have a wonderful supportive family and one grandson whom I have lots of fun with. My husband and I walk in the river valley every day and observe the changing seasons. We have an amazing garden, and gardening is one of my passions. I have traveled to Maui, Mexico, throughout the US, and within Canada with my neobladder. The only thing different is that I ensure I've packed all my supplies and put them in my carry-on. I go to the gym regularly and always have a catheter in my bag. As well, when I'm out shopping or meeting friends for lunch, I always have my supplies with me and know where the bathrooms are. So glad to have celebrated 7 years of being cancer-free this past June. Thank you.
Amazing, Gloria. Thank you so much for sharing. And I love that you said you tackled the day before you tackled the night, kind of just one thing at a time. And I'm so glad to hear that you're getting the DTC tax credit as well. We've heard some people with the neobladder had a little bit harder of a time finding the right wording on how their life is different than a regular bladder.
Mhm.
Great.
Yeah.
Well, thank
It
you
is
so much.
different.
Yes, exactly. Yeah. Okay, I've got a few questions, but I'll save them for the end. So thank you for sharing.
You're welcome.
Clarence, you are on the open sea on a cruise. Are you there?
Okay,
No
here I
problem.
am. I can see
Hello.
myself now. Oh my gosh, scared myself. I'm going to start off with, I've been 10 years now with a urostomy bag. So I've been June 2014. I had my surgery, and I've been wearing an external bag ever since. I was very fortunate that I didn't have any complications other than some severe, painful gas and bowel movements right after the surgery in that first week. Largely my own fault. I decided that I would get healthier faster if I ate solid food faster, and I snuck away the first night, and I had some toast and jam, and that, of course, caused all kinds of problems because when they create the ostomy, they use a small part of the intestine to create the ostomy, which means you have not only your bladder removed, you also have surgery to your bowel. And the bowel goes to sleep, and when it decides to wake up, it can be very painful if you force it into trying to work faster than it should. So my advice would be listen to your doctors, the professionals, and follow the treatment plan that they suggest. You can't force the issue to get better faster. My urostomy diversion supplies, they cost me approximately $585 every 2 months. In Alberta, $380 of that is covered by a program called Alberta AIDS for Daily Living, and the remaining is $205 is covered by private insurance. People outside of Alberta, most provinces do offer very similar or the same, in some situations even better. So I would advise any person having the need to get these supplies to check with your province and find out. Usually the ostomy nurses that provide care to you will help you get started to make sure you're getting these supplies at a reasonable cost. It took me about 3 to 4 weeks to find the right combination of urostomy pouch and flange and barrier ring. And I tried a number of different different time manufacturers, different types of things. And it took a while, about 3 to 4 weeks, until I was able to find something that I was happy with. And I've been using the same products for the last 10 years now. I recently have been thinking about maybe changing to a single bag. So the system that I have now is a 2-part. One part applies to your stomach, and then you attach a bag to that piece, and it has a little plastic clip. So for me, because my ostomy came out a little bit oblong shape, I can't use standard pre-manufactured cut appliance, so I have to cut it myself. So it's a little easier to cut it since it's open, and a little easier to place as a 2-piece. However, being one piece would have the advantage of, I've had on occasion over the 10 years, and a number of occasions, where actually the little plastic clip has popped open, and when it opens, it releases, and the seal is not tight, so that you can have a leak from the bag. So a 1-piece is kind of interesting to me now. Now I've got all this experience in cutting, I think I can cut it without having any problem. So I might try that. Otherwise, I'm quite happy with the results that I have with it. And the thing that I guess people wonder about, changing the bag and all of the situations. I had occasion once to take some people to view some chuck wagon races in the middle of Alberta in the summertime, and we got there. It was a wonderful event, except there was no public facilities there, just some outhouses outside, and we were caught in a thunderstorm, and it rained like crazy. And so during that time period, I needed to actually change my urostomy. And so I had to stand in about 2 or 3 inches inside a porta potty and make that change. Kind of an very unhygienic situation. But after that, I realized that there's really nothing that's unmanageable with external pouch. So it's not a problem. You can live with it quite well, quite easily. I've traveled extensively. Right now I'm on a trip. It's an 11-day cruise. I've been on a 31-day cruise, so I just packed enough supplies to last for 2 months. And make sure if you do travel that you carry it with you on the plane, because you can buy these supplies pretty much anywhere in the world. However, the anxiety is just not worth not carrying it with you. So I've got a few things here I'm going to say as a checklist, so to create fewer surprises, and I'll just read through them, is to check your appliance, to change your appliance while in the shower. It's easier changing. The cleanup is much easier, and you just have to keep the new apparatus dry. You need to touch your pouch to know when the bag is full, because if you don't touch it, there is no sensation saying, I have to pee. So you have to touch it to know how much is in your bag. I usually go somewhere between 2 and 3 hours before I have to touch it, or before I have to drain the bag. And at night, of course, I hook up to a nighttime bag so that I don't have to drain every 3 hours. I can go probably, I did on the cruise, I slept 9.5 hours the other day. So I don't know why, sea air, I guess. So very important to be able to do that. Another thing to remember is if you go to a restaurant, you go out to the theater, go to a play, is to make sure that you have fun, and but a libation or two sometimes makes you forget that you even have an appliance. So you want to make sure that you still touch the bag or be aware of your surroundings so that you know where the washroom is. You want to drain before you go swimming, and remember that 2 hours in the pool, that's a lot of urine in your bag, and it may show. So you want to make sure you get out of the pool and drain the bag after an hour or so. Same thing with I golf. So if I go for golf or I go for a walk, and you have to drain before. This is a common sense thing, and sometimes even people that have a bladder don't have enough common sense to use the washroom before they leave for the golf course. So little thing to remember that. Another little thing is a little tip when you're hooking up your nighttime bag, if you want to leave a little bit of urine in your ostomy pouch so that when you connect it to the nighttime bag, you have no opportunity to create an airlock. If you attach the two dry together, you could possibly, and it happened to me once, that I did have an airlock, and then what happened is the urine never drained into the nighttime bag. It just kept filling the urostomy pouch until it was so large that it actually caused a leak. So I also keep a small bag of clothing with me in the car, and a change, an ostomy change, prepared, pre-cut, and everything's ready to go, just in case I was to have an accident. And again, as I said, when you travel, go ahead and travel, just double whatever you think you're going to need, and then you'll be able to relax quite well on your vacation for whatever time frame it would be. Changing every 3 to 4 days is the norm for me, although I've sometimes ended up going a little longer, which is kind of crazy because it's so easy when you're in the shower to do. It takes like 5 minutes longer, so I don't know why. Sometimes I'm lazy and don't do it every 3 to 4 days. But it's well worth the 10 years I've had with my grandchildren to do that little bit of extra work to clean up. I also found that if I take a little bit of tissue paper, Kleenex or some toilet paper, and I put it on top of my ostomy where the connector piece is, I bring that to the top and lock it there. And I put a piece of tissue there is because what I found is that the elastic band from the waistband of my underwear is very kind of sticky tacky, and the tacky material, the hydrocolloid material that sticks to your body, it'll sometimes catch the edge of that, and then the elastic band will kind of stick to the ostomy bag, and then when you separate it, you have to pull and tear at it, and sometimes it'll cause an opening, and that could create a leak. So I just find it's easier to put the piece of tissue paper there to prevent that. Again, I said after surgery, I now sleep better and longer than I ever did in the months before and years before my diagnosis. I still have leak issues and some minor discomfort from time to time, and that's inevitable but never unmanageable. One last tidbit before I say goodbye is sometimes there can be a smell, particularly associated with your nighttime bag, because you don't want to use it and throw it away every day. So you hang on to it, use it for like 7 days. And by the 6th or 7th day, you can start to get a little bit of an odor. So what you can do is you can put a 6 parts water to 1 part vinegar solution and get it inside to the bag. I used to use an old ketchup bottle with a squeeze on it, and I'd mix the solution in there and then squeeze it into the nozzle of the nighttime bag. What I'm doing recently is I found an Airwick air freshener that has a dispenser end that's basically the same size as the opening to the nighttime bag, and I just give a few little squirts with that, and that seems to control that smell. And it's not something that you carry with you, or at least for me, it's not. But it does make the washroom a little smelly if the bag has been sitting there for 6 days hanging. That's it. I wish you well in your journey. Thank you.
Thank you, Clarence. That was a great overview. So many great tips. And I like that you mentioned how you tried a lot of different supplies as well, because I know that can be really important to find the right, the right solution for everyone.
Correct.
Great. Okay, well, we will save the questions for the Q&A portion for you, but we will pass it over to Dave now to speak about the Indiana pouch.
Hi, my name is Dave, and I'm a personal support volunteer for Bladder Cancer Canada. I underwent radical cystectomy surgery in October of 2014, and I chose this particular option. The reason I did that is because my brother-in-law, an American citizen, was the 50th person to ever receive the Indiana pouch after it was invented at the University of Indiana. As a result, over the years, I became very familiar with the Indiana pouch and was very impressed with the way it impacted his lifestyle. The Indiana pouch is a continent diversion, sometimes offered after surgery. It's connected to the a stoma on the external portion of the abdomen, and then also to the kidneys. The stoma is usually located just above the belt line in males and sometimes just below the belt line in females. It's slightly smaller than a 10-cent coin. It provides an external port for regular catheterization of urine from the body. It can hold up to 1 liter of urine, and it should be emptied on average every 4 hours, or more frequently depending on what you're consuming during the day. If you consume large amounts of fluid, just like a regular bladder, on occasion, my pouch does seem to have a mind of its own and decides to discharge on its own. Emptying the pouch is easily done by inserting the catheter through the stoma into the pouch. The urine will drain automatically until the pouch is empty. The catheter is then removed, rinsed internally and externally with water. Never use soap. Dried with a paper towel or a clean cloth and stored for future use. It now becomes a personal choice as to when you should replace the catheter. I use a highly absorbent, non-irritant, breathable stoma cap bandage with a fluid barrier for continent stoma, just in case some unexpected leakage, which can occur. I find that if I consume carbonated beverages, for example, beer, I will be in for some small surprises. Sometimes it can irritate the pouch and cause it to leak unexpectedly. My brother-in-law uses a small circular stoma bandage for his. The average cost of the catheter and bandages for myself in Ontario is around $180 a month. The province of Ontario provides stoma patients with just a little under $1,000 a month to help offset the cost of this. Always be aware that there's no guarantee that you will have a diversion that you exactly wish for. Sometimes previous surgeries can create an issue for a pouch location, and it cannot be performed in every case. I didn't know for sure that this was done until I woke up in recovery. Not all urologists also perform Indiana pouch surgeries. Everybody is different. Because it's not visible to anyone, no one could ever tell that I have an Indiana pouch, and that's one of the benefits. It's very, very not visible, and unless somebody notices a small circular bandage, if you're gone swimming or whatever, they won't know that you have it. The one thing you have to remember is that you have to remind yourself, just like the other individuals, you have to remind yourself that it's time to empty this pouch. Believe it or not, it becomes very easy to forget. On one occasion, I personally use a very good vibrating wristwatch. Other people use cell phones, whatever works for you. Believe it or not, you will forget on occasion, and I have. On one occasion, I was off doing things all day and forgot to empty the pouch. When I got home, I told my wife that I had stomach pains and didn't know why. She reminded me of one time I last emptied, which was about 8 hours previously. The pouch had expanded at that point and had 800 milliliters of urine, and as a result was pushing aside some of the other internal organs, which was quite painful. When I inserted the catheter, the pain flowed away with the urine. I flush the pouch every few months with a solution of vinegar and water to keep it clean. There is very little restriction with the Indiana pouch. I've been in hot tubs, salt and freshwater pools, lakes and oceans, virtually all over the world without any issues. I carry a small leather pouch in which I carry a catheter coiled up in a small plastic sleeve, a small tube of lubricant, a few bandages, and a couple of hand wipes, and that's it. I've traveled extensively without any problems whatsoever. Furthermore, I and my brother-in-law have never ever had one single infection as a result of having an Indiana pouch. Because it takes longer to empty an Indiana pouch than it does for a similar person of the same sex and age to urinate, I applied for it, just like Gloria did, and received a federal tax disability credit. This is a significant tax deduction. The federal tax department recalculated my tax returns for a full 10-year period, the maximum allowable, by the way, and issued me a significant amount of money. This tax credit will also be used in the future for tax returns forever. That's the story of the Indiana pouch.
Great. Thank you so much, Dave and Clarence and Gloria. So we always appreciate your willingness to share your story to help others. Thank you. So I will jump into the questions. I have quite a few already. So
Okay, first question. With the ileal conduit, are hernias quite common, and is there a limit to the amount of weight you should lift?
So, I mean, hernias can be an issue with all three. I'm looking at a peristomal hernia. Yes, it's not common, but it can be avoided. We find it more in people who are really physically active and individuals who do, like if they're working construction, so things where they're doing a lot of heavy lifting or the types of exercise. So we usually would recommend a belt that would keep everything more in place. So in accordance with a peristomal, there are assistive devices that can help to decrease that possibility. But everybody across the board is the same when it comes to surgical hernias. Everybody's the same with the restrictions, just of not doing any heavy lifting or abdominal core exercises. But for the ileal conduit, it would be sort of more long-term if they're doing a lot of like strenuous type of work, and that would affect the area.
Do you know what that weight limit is?
So it really kind of varies on the individual. So sometimes it would be, I mean, somebody could lift 20 pounds and get it, right? So, and some people it may be 100. So it's hard to say what the magic number would be. What we recommend is when someone is doing a lot of strenuous exercise to avoid having the peristomal hernia, that they should purchase the belt and wear it, just so that you're doing a preventative measure.
Okay.
Sort of like putting a Band-Aid if you're running a marathon, right? So like on your heel, it's the same thing. It's probably better to wear it if you are going to do something that's really strenuous.
For Gloria, how did you learn how to do the Crede Maneuver?
Actually, I went on website and I found a manual put out by University of Michigan, and in there they had the Crede maneuver, and it's basically you take your fist and you put it sort of in that above your pubic area, and you put your other hand over top of it and you apply pressure and push, and that's how you empty your neo.
what would you recommend, Gloria, if someone had difficulty emptying the neobladder fully?
I would recommend they learn to self-cath. It is so easy for a female. If you were used to putting in a tampon, a catheter just you know, you can use lubricant. I'm at the point now where I don't need lubricant any longer, but you just put some lubricant, the catheter goes in within, like I'd say, you go, you void and you're done. For me, now I can go into a stall in a bathroom and someone else can come in beside me and I can empty my bladder as quickly as that person. So it's just a matter of, you know, learning how to do all of that. And it's pretty slick.
So how did the three of you make the decision on which diversion to go? Was it, you know, any lifestyle choices that you thought would really affect it? Was it just simply recommended by your surgeon, or did you push for yours? I know, Dave, you had experience with your brother-in-law. Any other reason that you really wanted the Indiana pouch?
No, basically that was the whole reason. I spent a lot of time over the years with him. He had the Indiana pouch for just a little over 20 some odd years before he passed, and virtually, like I say, he never had an infection, never had any real issues, and his lifestyle was pretty well almost completely normal, save for the fact that, you know, on every 4 hours or so he would have to go and empty his pouch. But other than that, I found that to be, well, it's so insignificant for appearance-wise and for, you know, my ability to travel. Like I say, I've been all over the world. I carry that small leather pouch in my back pocket, and I've never had an issue in terms of being able to void the pouch. So that's one of the reasons I stayed with it.
Gloria?
For me, it was suggested by my surgeon that I do the Neobladder because I had just turned 60, so I was pretty young. I had a very active lifestyle. I used to like hike and bike and walk and go to the gym all the time. And so for me, it was about sort of body image as well. I wanted something as normal as what I had before. Although, you know, the Neo is quite different in, I guess I would say, you know, your bladder is very automatic. It's like an automatic camera. It just works. And Neo, it's manual. So you have to, you know, put some work into it to be able to void. But for me, I never considered any other option. And, you know, although when you go into surgery, you don't know until you wake up if you may choose the option that you want, but until the surgeons go inside and operate, you're not sure what you're going to get. So when I woke up and had the Neo, I was very excited because, you know, that was the option I wanted. And if I had to do it again, I would still choose the Neo. For me, it was the right choice.
Okay, great. And Clarence?
I chose the ileostomy because my doctor gave me two options, either not the Indiana, the neonatal or the ostomy, because that's all he had ever done. And so that was his field of scope of practice that he could do. He also told me some things that, you know, made me a little bit concerned. He told me that the chance of infection was greater with the Neobladder than it was with the ileostomy. And, you know, I always was a little bit on the portly side, so I'm not ever going to wear a Speedo again anyway. And so I kind of thought to myself, you know what, this would be the best option for me. I mean, I still swim, I still travel, I still do all those things, just not, I wear a pair of baggy swim trunks and that's it. So for me, that was the reason, because of his limited experience and the fact that he did tell me that the opportunity for more infection. Again, I was 60 years old and I thought I don't want to take the chance of being back in the hospital again. So, which is not necessarily true because there's still infection problems do happen, but that was my main reasoning.
Okay. And is it common to have white spots on a stoma?
No, so I mean, it depends on the type of white. So a lot of times white can mean infection, or it could be like a yeast infection. not that it's it doesn't have to be severe. Some people can just live with it, but sometimes it can just be the mucus that accumulates. That's actually more. It usually is clear, but sometimes can turn white once it's in the air. So it could be a lot of different factors. If somebody is symptomatic, then it should be looked at, and they can always, or if it's making the stoma really red, then that would be like a yeast infection. So it would really be something that they should have looked at and maybe swabbed and to find out if it is actually an infection or a yeast, in which case it could be managed simply with like some simple antibiotics. Maybe they don't need that. Maybe they just need the cream for the yeast infection. So, or maybe it's just how they're cleaning it. So there's a lot of different things that it could be.
Okay,
Yeah.
thank you. What would the different post-operative care look like for the different diversions?
So post-operative, probably the shortest hospital stay would be the Ileal Conduit. The surgery is shorter, it's 4 to 6 hours on average. People are in hospital on average, could be anywhere between 4 to 6, 7 days. It's sort of that learning process, right, of being able to manage the stoma. So even though home care is organized for all the different services, it's the ability to be able to manage it independently. You don't have to be an expert, but not have to run into a merge if your pouch falls off. So you should be able to manage it. With the Indiana and Neo, longer hospital stay because there's more intense training as to the flushing protocols and ensuring that they're aware of what the expectations are. And sometimes it takes some time to really understand, how much mucus is normal, not normal. It also involves, it's a bigger surgery, a larger extension of bowel. So sometimes the bowel function takes a little bit longer for that to come back after surgery. So typically that population may be in hospital for say 5 to 7 or 10 days, right? It's variable. So the length of stay would be shorter for the Ileal Conduit, longer. But the training, again, I should say that because we're doing a younger population, and I said there cannot be any cognitive involvement with the two more complicated surgeries, usually they catch on quicker. As opposed to say maybe somebody who's a lot older who's having an Ileal Conduit. So it's kind of interchangeable. Like there's a lot of other factors that really come into play with length of stay, recovery time, same sort of restrictions. Again, it's a learning curve, and it tends to be longer with the Neo and the Indiana because their tubes are in for a much longer period of time. And with each one, there's different steps that are required, such as the flushing and the catheterization. So with the Indiana and the Neo, people over time will say, I no longer have the sensation because we've taken that away from them, but they may feel like they start to understand what the pressure feels like. So they say, I feel a different sensation, and then that's how I know I have to empty my bladder or catheterize, right? So yeah, each one is a little bit different, but there's different aspects as to what's important. So those would be the majors, is managing the tubes or the pouching, and that's where everybody's a little bit different.
Okay.
And what was the biggest adjustment you feel you had to make after receiving your urinary diversion?
For me, it was the training. It took a long time. I was talking to male counterparts in my support group who said took them 3 months maybe, and they were pretty well trained, 3 to 6 months. I mean, at 14 months, I was still getting up all hours of the night. During the day, I had leakage problems. It just, you have to work hard at it. And I guess that's where the physiotherapy really helped, because you have to develop those pelvic floor muscles. Just doing Kegels isn't enough. You need to do much more in the pelvic area so that your pelvic floor becomes very strong. And it's just patience. It took time. I mean, for me, that was probably the most frustrating, because the information that I was sent home from the hospital with said, anywhere from 3 weeks to 3 months, you should be fully continent. Well, no, that doesn't happen. And the night continence took about 3 years. But what I did is one of the support people said, you know what, don't, concentrate on the day continence. And at night, just put on your big girl underwear and, you can leak, but get a good sleep and work on that. Once you have, sort of accomplished your daytime, then go to the night. And that's what I did. So once I started doing that, then everything, slowly over time fell into place. But now I don't have any accidents. I mean, I'm 7 years out now, but for me, it's been, it's the Neobladder has given me life again. I'm still here and it works. I haven't touched wood. I haven't had any complications other than the twisted bowel, but I don't get any UTIs. I don't suffer from that, and I don't have any leakage problems. So, I mean, other than I do have to get up in the middle of the night once, but I get up, it's like, I don't know, get up, do my thing, go back to bed, and I'm asleep. So it's pretty good.
Great, that's great. And Clarence?
I think initially the big thing for me was getting used to the fact that I had to do these changes every 3 or 4 days. And it, initially, I made a big production of it. My wife helped me make the change, and we took, oh gosh, we spent, close to a half hour making, changing from one appliance to the next. And within a 5, 6 weeks, maybe 2 months, we realized that this was craziness. I can do this by myself. And then it took less than 5 minutes to do it. So it was not a big issue. It wasn't as big as you make it out, because you're worried about cleanliness and you're worried about a whole bunch of stuff initially. And then the second big thing for me to get used to was the fact that I had to make sure that I checked the bag and drained it, because I would forget all the time. I just would forget. You just don't know that you start off your day. And I have situations where I'd go meet people, have dinner, sit down. I had one in, a business meeting that I attended, and sat down and had a few beers, and, we sat and talked, and all of a sudden I had a leak. And because I just didn't check, because I forget that I had the bag. And even now, sometimes I forget to check, 10 years later, I'll kind of get lapse and I won't check my bag, and then I'll have a leak. And so leaks are an issue that are always going to be there, because, it's like water. If there's an opportunity, it'll find a way to get out. So you just have to, resign yourself to that fact that it's not a big deal. It doesn't happen every day. It doesn't happen every week. It doesn't happen every month, but they do happen, and you get used to it.
And what about the idea of always having a bag on you? Is that something that kind of irritates you? I heard someone say no one prepared me for the fact that I would always have a bag on me. So I'm just curious how you feel about that.
No, it doesn't at all, because no one would know unless, like I said, unless, sometimes if, again, if I don't check myself and drain it every so often, if I'm drinking a lot that day, it'll get pretty bulky and there'll be a bulge. So people would notice that, but typically they don't see it. I mean, I don't, I'm not wearing, skinny jeans or anything. So you just can't tell. And wearing it, I guess the only time that it bugs me sometimes on the golf course, and I'm, I've drained before I started, but I'm on, playing golf or going for a long walk, and it's hot, and you have a bag of warm pee rubbing up against your leg. So that becomes a little irritating sometimes. But other than that, you don't even know it's there. For me, at least, I don't even know it's there.
Okay, thank you. And Dave, your biggest adjustment?
The biggest adjustment for me, as far as continence goes, I was continent from the moment I woke from the surgery. And like Gloria, it's the same thing. I must emphasize that you can wish all you like for a specific diversion, but you have to be really aware that you could wake up and not have what you wished for. And this is something I run into with a lot of the people that are facing radical cystectomy, and I talk to them about the Neobladder or about the Indiana pouch. The fact that like Gloria, I have to get up around the middle of the night to empty the pouch, and it takes me 3 or 4 minutes, and then I'm back to bed and asleep. And other than that, adjusting to it, when I first had woke from the surgery, I had to catheterize for every 2 hours for a couple of days, then increase it to 3 hours, then increase it to 4, 4.5, and that was my lifestyle after that. So the adjustment phase was very, very easy, and I really have no issues in terms of being self-conscious or anything like that at all, because it's not visible to anybody, and it's so easy to deal with. And like Clarence, I take my supplies with me. I take a supply of bandages and catheters with me whenever I travel, and actually, I have very little issue with the pouch in that sense.
Leah, just a clarification question for you. How long does it take to expand the Indiana pouch?
Months.
And then how many cc's of urine is the recommended amount?
So it should never exceed about 600 cc's. Now, there are people that stretch the limit. So we had one lady that had her Indiana 15 years ago. And so we were just going over things, and I said, oh yeah, with the 600. She goes, Leah, I haven't been 600 in 6 years. She goes, I'm at 1200. I'm like, oh my God, no. So she said, it took me a long time. She goes, I was doing kind of 50 cc's like at year after year type of thing. So, I mean, she had her Indiana, like it was 12 or 15 years ago. So she's kind of pushed the boundaries, but we usually would say it should not exceed 600, which is about average of what people hold in their bladder, right? So you are, again, putting undue pressure on something that is not in that position, and that's not what it was built for. So, and the tighter it gets, or the fuller it gets, the tighter the valve, you can't catheterize. So then that would be a visit to emerge. So that's where it's a fine line as to, you can maybe overfill it, but then you can't catheterize.
Okay.
Right? Because it's too much back pressure on the valve. So usually we say it's better to do the scheduling. And that's where some people will have it just on their watch. So it's like a little, mechanism that triggers them because they don't learn the sensation for quite some time, just to kind of stick to the schedule. In saying that, I know it's overwhelming. So what we do say to people is, especially in the first few months, if they do want, they can put an indwelling catheter, put one in with a balloon into their Indiana, and then sleep with a drainage bag so they can get a little bit longer sleep. So it's kind of cheating. But I find being able to get a good night's sleep really helps you problem solve, and that's how your body heals, right? So it's difficult to have to get up every 3 hours initially at nighttime, and then building up to 6 to 7 hours. And you can't really go longer than that with an Indiana, right? So some people will do that. There's adjustment to lifestyle. So I will say there was one that she wanted to go to Rolling Stones, and she said, I'm not catheterizing in the in the stalls in the field when they were in Barrie a few years ago. So she said, I'm just telling you, I'm catheterizing and doing a leg bag to go to the Rolling Stone concert, right? So I said, no, I think that's actually a smart idea compared to trying to catheterize in those dirty. So again, that's where having the ability to kind of think ahead and problem solve. This is what I need to do for this event in my life, right? So that's where people, giving them the tools, and they have the ability to be able to say, this is what I need and this is what I'm going to do.
Okay. Should samples of different appliances or supplies be requested from companies prior to surgery, or are you given samples when you leave the hospital?
In my case, I was, they tried to fit me in the hospital with an appliance. In Alberta, we have a care center in Calgary that deals specifically with urology problems. So we had urostomy, urology nurses there, and they helped you with the appliances and putting something on. And they sent me home with supplies, and it didn't work. Those ones didn't work very well. I had lots of issues with them. And so I went back to the nurses into the hospital and seen the ostomy nurse. And we played around, tried a few different, again, with a couple of manufacturers, three different ways of fixing the appliance. And then from that point forward, they directed me to home healthcare in Calgary, where I just phone them up and get the supplies, and they invoice the Alberta government for their share immediately, and then I submit the rest afterwards to my provincial or my private healthcare. But they started me off with supplies from the hospital, and then they were more than willing to say, well, if that didn't work for you, we can try this. I had some trouble with adhesive bandages sticking to my skin, so I had a little bit of a skin rash from the bandage. So they switched me to the hydrocolloid type adhesion, where that material, it warms up and softens, and it when it's in touch and contact with the skin, and then creates the seal. And that really worked well for me. So, but yeah, they start you off with something, and then obviously I think they'll work with you to find out something that works best for you.
Yeah, and isn't it some companies like Coloplast would send you a bunch of samples? Is that true?
Yeah. Well, I never got samples from Coloplast, but I believe they would do that. But that's the product that I use now. I started out with products from Hollinger, which is another major manufacturer. The two big manufacturers of the product are Hollinger and Coloplast, and either one will work for you depending on they all have different ways of attaching. The bag. The Hollister has a little valve system that lets you drain the bag, where the Coloplast system is a little plunger you have to pull out of the bag to drain it during the day. So there's a little bit of variance. They attach, but they're even interchangeable. So the product lines are interchangeable even within each other. So I use a Hollister barrier ring in conjunction with my Coloplast products. So kind of a mix and match. And that was, again, something that we worked on with the ostomy nurses to find the right thing for me. Because, of course, my anatomy is different from the next person and the next person and the next person. So everyone reacts a little bit differently to the type of appliance they provide you with.
What advice would you give to someone who had to make the decision on a diversion?
It's all on you. No, really, it's an informed consent is the most important aspect. And this is where collaboratively our team really has to work together, because we have to look at the whole psychological, physiological. We have to look at long term, do they need further treatments? There's so many aspects in those decisions. So there are some times when I think it's a mindset. Surgeons, we're all of the mindset, maybe if you're younger, you shouldn't have a pouch. And I think that's all our old sort of way of thinking, right? Just because the less obvious, the more normal, that's where we're wrong. And that's why I'm so happy with social media, because again, we're categorizing. In saying that, we had a young person who was, a respiratory therapist. The doctor came and said, did you talk her out of having like an Indiana? And I said, no, I didn't talk her out of it. And he said, well, she wants an Ileal Conduit. And I was like, oh, she'd be perfect. So I said, don't worry, I'll talk to her. So I talked to her. She goes, look, you're in healthcare. She said, so there's criteria with the Indiana. So I have to catheterize at a certain time, because if I don't, I can't get that catheter past that, the valve. So then I'm going to blow my pouch, or I have to go to emerge. So for my quality of life, if I'm called into a respiratory therapist is usually the one who's called in the hospital to go if somebody has a cardiac arrest. So she says, if I'm running to a cardiac arrest and I was just on my way to the bathroom to catheterize, I may be there for 3 hours. So what am I going to do? I'm going to tell somebody catheterize me when I'm in the middle of a code. She goes, worst comes to worst, I can say to my friend, unrelease the bag and I'll just wet my pants, right? Like with an Ileal Conduit. So she said, but I'm not going to do damage to my body by not catheterizing. So she said, for me, I'm young, I'm 40. I don't want to give up my job. I don't want to give up other things. I want the Ileal Conduit, right? So it's sort of, that's where them having the knowledge of what's involved in managing each one of the different types, it's their decision, right? And do I want, they have to weigh the options. Do I want this or do I want that? So literally probably the easiest management would really be the Ileal Conduit, because the other ones are a little bit more management. So yeah, it just, you have to weigh it. And the most important is an informed consent and asking like good questions and really knowing the different procedures. None of them are perfect, right? So it's which one can I live with?
Yeah, that's amazing how educated this person was and was able to be empowered that way to know what
Yeah,
was
and it
best
was
for her life.
because I literally thought, oh yeah, no, for sure, right? And it was like, no, look at this is this and this, right? And she goes, and you gave me all that information, so why are you questioning me now? And I was like, I don't know, I'm just saying. So I think there's a little bit of a stigma still that we all have, but it's yeah, some of the younger ones, and then I find sometimes it's some of the older ones that say, I don't want the pouch, because the stigma's still there from before. Whereas I think some of the younger generation now, this is where I'm saying, with social media and people saying, this is who I am, right? This does not define me. I think there's more of an awareness that this doesn't define. So, whereas I think the older generation tends to have that as a definition, right? So, yeah, so I think we're on a cusp, like we're just sort of like this when we're looking at how things are transitioning. So a lot of it is financial as well, because some people say I can't afford that, right? And the person we have one that's 20,000, the other one is 35,000, who's had the surgery with the Indiana, and cannot use a catheter more than once. It has to be thrown out, and it has to be the most expensive catheter, because any flaw in the catheter irritates the mucosa, and as soon as that mucosa is injured, like if you have a little cut, that's where the E. coli gets in. The E. coli goes into the bloodstream, and then she's in the hospital in the ICU. So this is where it almost took us really like 6 months to a year to figure out it was the catheters that was causing her all these infections and all these multiple hospital admissions, right? It took a while, and that's where it was like, could never clean the catheters, right? So and she said, I'm wealthy enough that I could live with that. There are people who can't. So she said, Lee, you need to tell people, right? And so then now it's part of our, it can be, and that's where we're more aware. And even with the residents, right? It's training the younger physicians who are going out and doing these surgeries, because a lot of times patients don't share that information with their doctors. So people kind of keep it to themselves. But that is, again, comes into that informed consent, that this can be an option.
Okay, great. And last question for everyone. Is there anything you wish you knew going into surgery?
Going into surgery, I wish I would have known how the neobladder behaved and how much work you had to put into it, because I would never really told that. And the literature I read, it sounded like it was going to be pretty easy, but it was a lot of work. No one told me about physiotherapy, as they say, other than talking to a Bladder Cancer Canada volunteer, and she mentioned that. But I guess for me, going into it is learn as much you can upfront about the neo and how much work it's going to take, and decide then if this is truly a diversion for you. Because if you're not willing to put in the work, like for me, I was bound and determined I was going to be continent day and night, and I strive to do that, and I have achieved it. But not everybody wants to put in the kind of work that's involved with a neo, because it is a lot of work. And but as I said, you know, you kind of get out of it what you put into it. So that's all I would say about it.
Okay, thank you. And Clarence.
I I wished I would have known a lot before surgery. I wish I'd have known about Bladder Cancer Canada before surgery. I wish I would have had that Bladder Cancer Canada as a resource so I could be very well informed of all the opportunities that were afforded to me, and any new things that go on. Bladder Cancer Canada seems to know about it. So at the time, I knew nothing about bladder cancer. All I knew that cancer was probably going to kill me, and I was very scared and very nervous. And I wish I'd have known a lot more about it and had a bigger resource to find. All in all, everything's worked out for me. I'm here still 10 years later, and I'm as healthy as I've ever been. And the diversion I chose works fine for me, but it would have been much better to be more informed. So I hope that everyone continues along this path of volunteering and working with Bladder Canada cancers, because it's a big help to people. So that's what I wish. I wish I knew a lot more than I did.
Great, thanks, Clarence. And Dave.
In my case, I wasn't really concerned about the surgery, except for the fact, like Gloria said, that when you wake up, you really don't know until you ask the nurse standing beside you whether it's in or it's out. And that was the first question I said, was it inside or outside? And she said inside. So I closed my eyes and went off back to sleep for quite a while. But I wish I had known a little more about the connotations of major surgery in all of these cases, how it affects the sexual organs and your lifestyle in terms of, that type of thing. That wasn't something that I was offered. And I do, as a volunteer, make sure to tell everybody that, ask all the questions and make sure you get as many answers as you can before the surgery so that waking up is not a major surprise for you.
Yeah, great. And I just saw one last question in the chat. Can the Indiana pouch be converted to an ostomy later?
I believe if you reverse the Indiana pouch, you would end up with an ileal conduit. Yeah.
Yeah, I think you're right. And I think same with Neobladder, right? You could go Neobladder to Indiana pouch, Neobladder to Ileal Conduit, but you can't go Ileal Conduit to a Neobladder.
Correct.
Right.
We did it once. It is not ideal, and it's extreme circumstances where any surgeon would really consider that.
Yeah.
So and the one that we did, if we did not correct it, she would have gone on dialysis, right? So we did have to, take it and remove and go to the ileal conduit, just because of the number of issues that they were having. So in saying that, it's sort of like a one-off where these things happen. It's very, very rare that anybody would really consider, because technically when you do surgery, there's a lot of adhesions, and because it's such a complex surgery, it's really the adhesions inside the body. You're also altering the length of the ureter. So being able to then use it to do an ileal conduit sometimes is difficult, right? So you don't have enough give in the ureters, because they still have to have that peristaltic movement. So it's rare.
Thank you so much, everyone. We recently posted a blog about urinary diversion options on our website, so this post will link you to additional information, support options, and resources, including a link to the Canadian Urinary Diversion Position Statement. And this is a collaboration between the CUA, NSWAC, and CNU. It has a great decision aid, so check out the website for that. It's linked right on our homepage. And I saw a question in the chat about the disability tax credit and finding the right wording. We recently released a great resource for that. It's for medical professionals, but it's also intended for patients to read through it. And then you can also bring that to your medical professional and show them suggested terminology to use or phrases to use to explain how living with a urinary diversion is considered a disability. So make sure to check that out. It's also linked on our website on the homepage as a blog, and I'll link it in this urinary diversion blog as well.
Thank you again, Leah, Gloria, Clarence, and Dave. We're so grateful for your time, passion, and your knowledge. Thank you to everyone who attended, and I hope you have a great night.
Thank you.
Thank-
Thank you.
Night.
Good night.
Bye-bye.